lumbar stenosis was caused by multiple structural reasons, mainly because of degenerative changes. It's caused by the bulging of disc from the anterior part and the thickness and the wrinkles of ligament flavum in the posterior, and the enlargement of the facet joints on the lateral. So the lumbar stenosis was caused by the surrounding structures around. So any part of decompression can be effective. Like usually we did posterior decompression and we removed the laminectomy. So there, here are the most common surgeries we did today for lumbar stenosis. On the left is the laminectomy from the posterior approach to remove the lamina and expose the dura sac and nerve roots. As well as it does lots of damage to the posterior ligament complex and the paraspinal muscles. Sometimes if we damage the stable structures, we have to reconstruct it. If there's any risk of instability, we have to fuse the spine with a pedic screw and intervertebral fusion device. And then we came into a tubular surgery period about 20 or 30 years ago, and lots of surgeons, they do the misty leaf. It's one kind of tubular surgery with microscope. And nowadays, we enter the endoscope surgery. So according to just now, the surgery I present, there are several corresponding surgery we can finish through endoscopic way, like endoscopic laminectomy. It's a uniportal technique, and unilateral laminectomy for bilateral decompression, as well as biportal endoscopic surgery. We name it UBE. So we unilateral and insert 2 tubers, and one is for vision, another is for instrument, and then the endoscopic fusion surgery for any kind of instability of spine. We can finish the fusion surgery by uniportal or biportal. Firstly, I would like to show the one of the most common surgery we did today, and endoscopic laminectomy. We adhere to the basic principles of a traditional open laminectomy surgery. We just finish the same traditional open surgery through endoscopic tool. Like we remove the part of the inferior facet process and part of the lamina to expose the dura sac and nerve roots. For lateral recess stenosis, and we move the working zone to the lateral side of isthmus. Here's some screen captured pictures we did during operation, and after inserting the tube, we can not see nothing, just redness and bleeding. We use radio frequency probe to stop bleeding, and we use trim fine to remove the articular processes and the lamina. Finally, we expose the ligament flavum and was removed by punches, and dura sac and nerve root was well exposed and protected. Next is unilateral laminectomy for bilateral decompression. We overtop the dura sac and cross to the contralateral side to remove the lamina and the inferior facet processes to decompress. The picture on the right is a very effective and powerful tool to remove bone under endoscopy. We name it Chuanchao. Here's the video we did. Now we use radio frequency probe to stop bleeding and probe any soft tissues or bone tissues. Finally, we debride the soft tissues from laminar and use trephine to remove the laminar and partial inferior facet processes. Generally, we decompress ipsilateral side firstly, and then get over top of the dura sac to decompress on the lateral side. That's a ligament flavum was removed by punches, and we can see after removing the ligament flavum, we can see the dura sac and traversing nerve root. Now the surgery will enter in a full endoscopic vision period. We can see much more clearly than traditional open surgery because of the bleeding. That's on the contralateral side of the lateral recess. Hit the dura sac, and on the ipsilateral side, well decompressed. And that's the contralateral side, well decompressed as well. This surgery is indicated for the bilateral stenosis. And next is unilateral biportal endoscopy surgery. It's two portals. It arises evolution from joint keyhole surgery. It's one hand for instrument tool, another hand is for endoscopy. Here's a photograph. We can see the V point is vision point is for endoscopy tube, and W is working cannula for an instrument tool, and the two tubes connected at the joint between lamina and spinal process. We can use punches to decompress on the ipsilateral side, as well as over top the dura sac, and decompress on the contralateral side. Here's some pictures we captured during operation. Firstly, we decompress on the ipsilateral side, and then remove the ligament flavum and decompress on the contralateral side. Here's a short video we did for UBE, unilateral biportal endoscopic surgery. We use high-speed burr to remove the laminar as well as the facet processes. With punches, after we make thinner of the laminar with burr, we use punches to remove the inner cortical of the laminar. We can see clearly of the dura sac. Diamond burr is a very high effective tool to remove bone under endoscopy. It can reduce bleeding. We overcross the top of the dura sac, and we come to on the contralateral side. Okay, sometimes we have to fuse the the pathological segments because of the instability exist. We often do it, traditionally by open surgery. After we insert a cage. There are two kinds of surgery. One is post-PLIF, the posterior lumbar intervertebral fusion, and another is TLIF. TLIF means transforaminal, more on the lateral side. Now, the endoscopic, just a mix it. It can fix the, it can fusion or finish the fusion surgery between the borders of PLIF or TLIF. Here's some X-rays I did for endoscopic fusion surgery. Firstly, I insert paddock screws on the contralateral side, and I remain the guide wires in the pedicle for the time being, and I decompress firstly, and then I insert cage device between the intervertebral disc, and finally the spondylolysis was well reduced. Here's some primary retrospective readouts of 6 years experiences. The 3 endoscopic surgery for lumbar stenosis have their own special indications or contraindications. Endolaminectomy is just for unilateral symptoms. And contraindications were bilateral symptoms and over 2 degrees of spondylolysis. We have over 3,000 cases. Excellent and good readouts were 87%. But for ULBD, it is indicated for bilateral symptoms, but contraindicated for the patients with over 2 degrees of spondylolysis. For UBE, it's bilateral symptoms only. It have to be handled by 2 hands. And the contraindications is still controversy. Some endoscopic spine surgeons think UBE can finish over 2 degrees of spondylolysis, but still, can exist controversy about that. It needs long-term follow-up. Overall, excellent and good outcomes for the 3 surgeries were 81.4%. In details, the JOA score and the visual analog score for both back and lower extremity, and were both significantly improved compared with the preoperative situation. And the rate of reoperation, we can see the non-fusion has a much lower rate of reoperation compared with the fusion surgery for ULBD and UBE. About the complications for 6 years experiences, the dural tear is the #1 complications, especially for unilateral bipolar decompression and UBE, unilateral laminotomy for bilateral decompression, because it have to overcome the top of the dural sac during removing the ligament flavum, the punches, sometimes cause the tear of the dural. These 3 surgeries have a much lower surgical site infection compared with traditional open surgery, and nerve root injury is almost the same compared with the traditional open surgery. The rate of reoperations are also one of the complications. About 6 years rate of reoperation, non-fusion for 1 level of lumbar stenosis is an independent risk factor. The take-home message: adhere to the basic principles of the traditional open decompression surgery. Endoscopic system is not only a tool to finish decompression surgery. It has its own wisdom, philosophy, and logics. Endoscopic decompression surgery is at least as effective as open surgery, with less injury to posterior ligament complex and other structures. It has less surgical site infection, while dural tear rate was not significantly reduced compared with the traditional open surgeries. We have to be judiciously to practice, summarize, and evaluate the techniques. It's very important to get enough evidence and data to show the degenerative, the proximal or distal adjacent segment degeneration may not getting worsen than the traditional posterior surgery. Welcome to Henan. It's the central part of China. Has the longest history of China. It's the China Han culture originating place. Welcome. That's all. Thank you.
Thank you, Dr. Chuanchao, for your wonderful lecture. Actually, it was a great lecture on endoscopic spine surgery for lumbar canal stenosis. Actually, we have one question by Dr. Osnat. I would like to ask her directly to unmute herself and ask the question for a fruitful discussion. Thank you.